previous session we had discussed about the examination of the spine. Now the next is about the diseases related to the spines. Among them, the most common and the most important is the diseases related to the intervertebral disc. Now intervertebral disc is a very specified structure where you will have a nucleus pulposus in the middle and surrounded by the annular structures which keep that somewhat flexible and somewhat soft also, and it acts as a buffer. Now the lesions related to the disc, they are maybe categorized as either the disc bulge, where it will be the middle area, the annular nucleus pulposus area, it becomes bulged, swollen, and the fibers, annular fibers may remain intact. And this is a stage where there would be an inflammatory pathology, and the inflammatory pathology would be presented with the specific nucleotides. Many of the nucleic acids now are identified. Even these immunological factors also are now identified, and it's called as HLA-B17, one of these immune substances which are now are antibodies which are identified now, and at times it could be considered as a autoimmune sort of the lesions also many times, or even it could be due to as a result of the inflammation. Now HLA-B17 now is limited only to ankylosing pathology, where there is a autonomous pathologies. Whereas in the other conditions it could be the other phospholipids which could be identified, which are the mediators of the inflammation. So disc bulge is the one initial stage. Now once the disc bulges, the next consequence, if it progresses, it may result in a protrusion where there will be some annular fibers also will become damaged. As you see over here in this image, it becomes somewhat damaged and becomes rigid. Now at that stage the clinical presentation also will be changing, right? Then if it progresses further, there would be a disc extrusion where the bulge would be extending into the annular fiber area, but it remains intact. It doesn't get in beyond that borders. The borders will be at the same area. Then the last stage is the disc sequestration, where the disc becomes hardened and it slips and it goes penetrates or maybe moves out of the area and gets either into the spinal canal or it may be into the anterior surface. Either it's the anterior or the posterior. Sequestration may occur and the disc piece may be broken off and from the nucleus pulposus. That's what we see in these images. So the pathology is a progressive condition. Clinically, to identify these, of course, we have some guidelines, but often it's quite difficult. And the condition is gradually progressive, stage by stage, and you cannot just pinpoint exactly at which stage the change has occurred. And hence, I would prefer to use the word disc lesion as a common word for all these stages, right? Though the approach to the treatment would be varying based upon the clinical presentation as such. So disc lesion is a very broader term used for all these sorts of the pathologies. Now the confirmation of these can be made out by the images, and MRI is a better tool to make the diagnosis, whereas plain X-ray also can show that differentiation only in the later stages of disc sequestration as such. Earlier conditions, disc bulge with the plain X-ray is quite difficult to make out. In the this MRI conditions, we can make out the disc bulge, where the space is increased, and then the last stage where the disc has penetrated beyond, and then there is a spinal canal stenosis. The spinal canal has become narrow. In the MRI image again, the images could be seen as a bulging disc where they can see that higher density in the central area, and the paracentral protrusion where the disc slightly, that annular nucleus pulposus slightly gets displaced, and then there is a sequestration of the disc material, and the extrusion where the disc has become completely displaced and then got into the spinal canal, producing the compression of the spinal canal. So MRI images can make out that differentiation easily. Now from the clinical course point of view, these conditions again may be categorized into three categories: dysfunction categories, instability category stage and restabilization stage. That's the as the clinical symptoms evolve during the initial stages of the disc bulge and the sequestration stages. There will be impaired function. The patient would have pain and the functions will be impaired, but still the patient will be able to do the normal day-to-day activities because it is stable. Now, when the patient, it results in the further stages progresses, it results in an unstable condition where the patient would not be able to support the back, weight also would be affected. Hence, the position of the patient, the posture of the patient would be altered, and that's what we call as the instability stage. And later on further, the patient gets adjusted to that stage. There will be either a permanent kyphosis or scoliosis or any such deformities which are permanent, and there would be even changes in the bone structures. Osteophytes may develop, and that is called as destabilization. So, though the disc lesions from the basic point of pathology, we may categorize based upon the these changes in the disc like bulge, sequestration and so on. From the clinical point of view, rather more important from the clinical point of view is identification of these stages like dysfunction stage, instability and destabilization stage. Now the dysfunction stage involves during the annular tears and separation of the end plate, where the impact of the disc bulge would be producing the these changes in the vertebral column structure also. Vertebral column structure would be affected. There will be a facet joints would be showing the reactions, synovial reactions. Rather, when it comes to the question of clinical symptoms, the clinical symptoms are produced due to the inflammation of the facet joints in that condition, and the nucleus pulposus usually loses its normal water imbibing abilities. And at this stage, the clinical symptoms are there will be low back pain or neck pain if it is in the cervical vertebrae, and the movement only there will be pain during the movement in the resting condition, and in certain positions there will be not much of a pain, and there will be local tenderness, muscles will be contracted, the range of movement would be lesser, the patient would have more pain during the extension of the back or the neck or maybe both area. And otherwise, if you do the neurological examination, all the other neurological examination may look normal. So that's the stage of dysfunction where there are no neurological deficiencies. The pain, the local pain, tenderness at the area, but and spasm of the muscles would be the characteristic feature. And a good number of patients who come to us, they come at this stage. And this can be made out by the MRI scan, but theoretically, very accurate diagnosis of this can be made out by this biopsy of annulus and electron microscopy, which is generally not seen. Whereas in the MRI, the features are the intervertebral discs seem to be dried up, hardened, the density would be more, and they gradually even desiccate. The shape may be or the space may be reduced. That's what you see in MRI. Either it could be bulged or it may become just dried up at that stage of dysfunction. Then the stage of instability, the disc is becomes somewhat thinner and the space is lost. The intervertebral disc space becomes reduced because the disc becomes thinner at the area, as there is a involvement of the annular fiber area, and it may result in somewhat a increased range of movement. Subluxation can occur, and hence at that situation the patient may feel like there is a giving away or a catch, like all of a sudden when the patient moves, all of a sudden the patient feels there is a restriction of the movement and further he cannot move. And this is very typical clinical symptom. So from the clinical point of view, the symptom of having a pain only on the movement and a pain suddenly occurring during a specific type of the movement, that makes the difference. And the patient, because of the pain, patient tends to stand with the flexion. Otherwise, there may be not much of a significant change. At times, it results in the movement becomes abnormal. Like the patient may have a sudden catch or shift when the patient moves around or when the patient bends forwards. So that would be the typical feature. In the MRI image at that stage, the disc space being reduced, as you see in this image, is the characteristic feature, and the cartilages, it may again, that space reduction may be confirmed or may be demonstrated by repeating the images at different positions, but usually it is not done. In a single position also we can make out that. That suggests about the stage of instability. Then the stage of restabilization, there will be progressive degenerative changes which result in changes of the vertebral bone structures. There will be osteophytes, the changes in the bones can occur. At this stage, even a plain X-ray can make out the changes very clearly. Vertebral body shape would be altered, there will be increased density, osteophytes would occur. And in that condition, the patient would have clinical symptom which is a constant pain, but the severity becomes reduced. The pain symptom would be low back pain which is constant, steady, but unlike that of the acute conditions where the pain will be acute, here it becomes constant and somewhat aching type of the pain would be presented. And the other signs are that muscles will be tender and there will be stiffness, total range of the movement would be altered. There could be either scoliosis or kyphosis depending upon the type of the defect. And in the CT scan or MRI also the same changes are seen. The vertebral bodies show that osteophytic changes, disc could be bulged, and there could be even a intrusion into the spinal canal, and that's what is occurring. The next stage of course would be a spinal canal stenosis. Now we will discuss spinal canal stenosis separately because it comes to the range of neurological deficits at that stage. So that part we will discuss later. Now the typical clinical symptoms would be that the patient would have a symptom which is usually related to some traumatic event. Though the pathology is a slowly progressive pathology, the patient would complain that the pain has started when patient has bent somewhat or during certain activities like lifting weight or so on. So suddenly the pain would occur. That's how the patient would describe the symptoms. So often it looks like a spontaneous onset of the symptoms, but actually the pathology is a progressive pathology. Then usually the symptoms would be in the low lumbar region or the buttocks, which can vary, and it even may be referred to either superior side towards the thoracic area or towards the abdomen or the flanks or even towards the lower area like thighs, knees or calf muscles, ankles, feet and toes. This depends upon the impact on the nerve fibers, which of the nerve fibers which are involved. And typically discogenic pain is exacerbated by activities like load on the disc, sitting, arising from a seated position, getting up from the sitting position, early morning, awakening in the morning, and when the patient is flexing, lumbar flexion with rotation, so on, or vibration. Another important is vibration, like riding a car or so on, coughing, sneezing, laughing, etc. Or Valsalva's maneuver. Valsalva's maneuver is when you hold the breath and then increase the pressure in the pulmonary area. Try to blow the air, that kind of a maneuver. Now they are reduced, the symptoms are reduced by lying on the side with hips and knees flexed. So that's what we call as a fetal position. Characteristically, most of the patients with a disc pathology would prefer to lie down in a position where the patient would be flexing the hip and the knees also are flexed partially, and the patient lies down on one side. Changing the position may aggravate the pain. Then usually it is described as aching pain. However, it could be like severeness could be of different category like soreness or stabbing and so on. Then if the patient had undergone a surgery earlier, lumbar arthrodesis surgery or lumbar discectomy or lumbar laminectomy, in such conditions there is always a high possibility of the discogenic diseases, and they tend to be having atypical pain. The symptoms will be atypical, may not be exactly as it is. It could be like either a constant pain, many times it could be only at certain positions the patient may have pain. And from our clinical point of view, majority of the patients who come to us are of that category. Now, when a patient comes to with a history of disc lesion or symptoms suggestive of disc lesion, it is quite necessary that you will have to take the history of other diseases which can trigger the pathology or trigger the changes in the bones. Like medical history should be investigated to rule out cancer, arthritis like conditions, arthritis, rheumatoid arthritis also can present with the pathology, systemic diseases which could increase the infections. Then they should also, you have to take the history of fever, incontinence, suggestive of metastasis. So one of the most common condition which can produce a confusion with the disc lesion is tumors in the bones, vertebral column there, and psychological issues also are to be done. Now, plain X-ray in disc pathology has a limitation. Only when in the later stages it can be useful, or in the early stages plain X-ray can be useful to rule out the diagnosis like tumors, fractures, etc., which also can present with the similar condition. So that tumors, fractures, such conditions we will see keep it separated. Now in the plain X-ray in the initial stages there will be no changes, it looks like normal, but in the and that's what we call as grade 0 in the plain X-ray. It all depends upon the clinical symptoms at that stage. The diagnosis will be based upon the clinical symptoms at that stage. But in the next stage there will be a disc space narrowing, and there could be even osteophytes, and usually the osteophytes start at the anterior side. Then there could be a spondylolisthesis. In the next stage the disc becomes hardened, it also becomes opaque, osteophytes tend to develop, and the axis of the vertebral bodies may change, that may be a shift that, and that's what we call as the listhesis, spondylolisthesis can occur. CT images at that stage also would be showing the same osteophytic changes and the disc bulge. The disc bulge is clearly seen in the CT scan, and the changes in the disc like the fibers, annular fibers being damaged, and the protrusion at that area also can be made out with the CT scan. But MRI are considered as a benchmark in all these conditions. Ideal tool of investigation would be the MRI. And the MRI again, in the early stage it will be the bulging which is seen. The next stage, the space being altered, there will be a narrowing of the space, and in the next stage the disc protrusion, and in the last stage there will be osteophytic changes, bone changes of the vertebral bodies would occur, and there will be myelopathy. The vertebral, the spinal cord becomes degenerated, and the changes in the consistency of the spinal cord could be seen. That is the last stage as such. The other investigation which could be of choice to rule out this spinal canal stenosis or obstruction to the spinal canal or myelopathy could be myelography, which is not done routinely. In the myelography, you inject a radiopaque dye into the CSF and then take the scan where these horstrations or these bulged disc producing the impression of the spinal canal can be made out, and that's the other investigation. The foramen stenosis, one of the other complications of the disc bulge would be the intervertebral disc foramen, the neural foramen. It may become obstructed, and that obstruction or blocked like that cannot be made out in the plain X-ray. It can be made out only with the MRI with the T2 and T1 densities. The space this foraminal space may be reduced, and patients who have radiculopathy, pain in the radicals along the nerve roots, can be made out with the images of this sort. And this is one of the important issues. Whenever you look at the MRI image, it's not only the spaces of the disc which you have to see and the spinal canal, the spaces of the foramen also should be visible. The foramen to be visible, you need to have the horizontal X-ray, the vertebral bodies have to be seen, and the foramen depth can be really made out with this, and that's one of the important observations, so correct about that. As far as the treatment is concerned, the usual therapy which is advised by the usual is in the early stages relative rest, which restricts all occupational and avocational activities for up to first 2 days with an acute episode, usually is indicated to reduce the pain. And the rest for longer period has not been shown to be beneficial and can cause deconditioning and loss of bone sensitivity, decreased intradiscal nutrition, loss of muscle strength, flexibility, and increased segmental stiffness. Now this is the issue of controversy. The earlier it was believed that the patient has to be given rest for 2 weeks, but now the latest is the rest should not be more than for 2 days. After 2 days the patient has to be mobilized. What I have observed is early mobilization and the patients stimulating the patient to encouraging the patient to walk and do the regular exercises would help in early recovery, though during the movement the patient may have pain, but that recovery during the movement would be always more beneficial. It is reduces the chances of longer, prolonged complications and permanent changes. Whereas the contemporary orthopedicians or even the neurologists here usually still stick on for 2 weeks bed rest schedule, or many times it could be 4 weeks bed rest schedule, where the patient is asked to take rest for a longer period. But now it is known, it is proved that longer period rest would be having longer complications, prolonged complications, like the patient would become deconditioned, he will not be able to walk further, bone density would be reduced, and it also can affect the status of the disc and the bones, muscle strength will be reduced, and hence all that complications will occur. The other options which are tried is steroid injections or electrothermal therapy are the other options which are tried in the present day situation. In the physical therapy, the options which are tried are either the lumbar traction, where a continuous traction is placed in the lumbar area and of course the patient is immobilized, or now there is another alternative, vertebral axial decompression, where there is a traction as well as a compression, pressure with a compressor at the lumbar area also is tried as options of the physical therapy. Exercises are suggested, and the usual exercises, series of exercises suggested are all complication, the pelvic and stretch and partial curve as such, and double knee to chest positions. These are all the complex exercises which are usually suggested by the physiotherapist. But what I have observed is these complex exercises are not needed. A simple leg raising exercise is good enough to help the patient in recovery, and I usually limit advice to these leg raising exercise alone, not the other complex exercises. With the complex exercise, there are two issues. One, the patient is, it's difficult for the patient to follow all the schedules. The other part is, at times if you are these positions are not very accurate, or if the patient is doing the exercise in the later stages of instability. Now, exercises can help, these exercises can help only in the initial stages of disc bulge. But if the patient has resulted in the reached stages of the disc extrusion, many of these exercises can aggravate the symptom if at all the sufficient care is not taken. So I usually prefer to limit only to the leg raising exercise, which is harmless even in the advanced stages. Even in the advanced stages it can be done. Only thing is, in the advanced stages, when there is a real reduction in the passage space, patient would not be able to raise the leg up to this level. If the level raised could be lesser, and in such conditions there will be another advantage. The progress of the condition status can be made out by looking at the position in which the patient can raise the leg. Initially, if the patient is able to raise the leg only to 10 to 15 degrees, and then after the treatment or during the treatment, if the patient can raise the leg up to 60 degrees or 70 degrees, then we can say that yes, our treatment is really benefiting the patient. So it also can have that prognostic value, or assessment, the clinical assessment also is done by that. And once the patient is able to raise the leg up to 60 degrees, 90 degrees, we can say that the patient, that the facet compression, radical compression is relieved completely. So that's how it is done. Then the usual standard protocol of the treatment are like the lumbar, as I said, back exercise, medications like NSAIDs are now usually given, then injections over there are the other treatment. Approximately 5% of the patients may require surgical treatment, and either it will be lumbar procedures or it depends upon the indications. Lumbar surgery is indicated particularly those with severe spinal canal stenosis or intractable pain, and those who are 6 to 12 months of non-operative course of treatment fails. Now, from my clinical point of view, when I prescribe the treatment, of course exercises is one of the common issue, and if the patient is in the dysfunction stage, I would consider this as kapha, and my prescription would be usually Gokshiradi Kukulu Vishamusvati and Avipatika Churna, usually Avipatika Churna mixed with Godanti. In the instability stage, I would consider this as a Sandhikatapata. In the dysfunction stage, either is a kapha, or I may write the diagnosis as simply Shula, Sandhi Shula. And in the instability stage, it is a real Sandhikatapata where there is a structural abnormality, and in that condition I would prefer the same Gokshirabhi or Chandraprabha depending upon whether there is involvement of the bone or not. Vishamuswati, Ashwagandharishta, Katibasti and Dashamula Nirugabasti is an optimum treatment at that stage where there could be a significant benefit. In the instability stage, the changes, the benefit of our treatment is really significant, and the patients would have very satisfactory relief. But if the patient has reached that restabilization stage where there is I would consider this a Dhatakshajarya Vyadhi, the outcome is unpredictable, but our treatment is definitely much better than the other, and the treatment is Chandraprabha, Ekangvira, Abraka, Tapyadi Godindya, the usual prescription, and Katibasti with Dashamula or Rajayapanabasti. Rajayapanabasti is preferred if there is a gross osteophytic changes. Now, another of the complications of these and related issues are spinal canal stenosis. Now, it may not be spinal canal stenosis is not only related to the interrupted disc pathology. It could occur due to multiple conditions. So, when a patient presents with spinal canal stenosis, you have to confirm whether it's really due to the herniated disc or whether it is due to other conditions. The other conditions which can produce the spinal canal stenosis are ligamentum flavum hypertrophy, the hypertrophy of ligamentum flavum, which can be a cause, and of course often it's also related to the internal disc pathologies also, and the inferior articulating process or facet hypertrophy of the interrotable discs. I will show you that what I mean by that. Then osteophytosis or fractures, compression fractures, which could be due to either the trauma or maybe pathological fractures. So these have to be ruled out. Now, the spinal stenosis clinical symptoms would be, once there is a spinal canal stenosis, either due to the interrotable disc pathology or the other causes, the main clinical symptom will be there will be a neurogenic claudication. Claudication is the pain which is related to the amount of the exercise. All of a sudden, the patient would have a pain after certain amount of the exercise, then it is relieved. But characteristically, that neurogenic claudication is differentiated from the vascular claudication. In the vascular claudication also the symptom would be similar, like the pain would occur after the exercise. But in a typical neurogenic claudication, acute pain would occur when the patient gets up from the resting condition, or in the sleep when the patient changes the position, there would be pain in a case of neurological claudication, whereas in case of vascular claudication there will be no pain during the sleep or resting condition. Only when the patient walks, the patient would have a pain. So that's how it has to be differentiated. And the other symptoms like midline, back pain and radiculopathy, they are common even in case of the interrotable disc pathologies, which we have already discussed. And in case of severe lumbar stenosis, the innervation of the urinary bladder and the rectum may be affected, resulting in either incontinence of the urine or loss of bladder control. The other important is looking at the tone of the muscles and bulk of the muscles. The motor signs where the muscles will become either atrophy or their tone is reduced is another quite important clinical sign to make the diagnosis of spinal canal stenosis. Or even there could be occasionally sensory symptoms like hyperesthesia also can occur in such conditions. Now, ligamentum flavum hypertrophy, which can occur due to multiple causes. Ligamentum flavum hypertrophy could be related to the autoimmune disorders, or it could be due to the previous injury, or it could be due to a constant occupational factor like there is a continuous strain. The ligamentum flavum is the ligament which supports the interspinous space, as well as it keeps the spinal canal intact. Now, it can, on an average, in the normal thickness of this ligamentum flavum is 3.5 millimeter, but it may get increased, and that itself can be a cause for the spinal canal stenosis. So when you do the MRI, and particularly in the MRI horizontal view, that thickness of the ligamentum flavum can be made out, and it can be like 4.5 mm or 5 mm or so on. So with an objective the scan image, the thickness can be objectively measured also. So ligamentum flavum, and that patient can have a spinal canal stenosis. The spinal canal stenosis can occur. About 70% of the patients who have a intervertebral disc pathology and they come at the extrusion stage, the later stages, they also have the ligamentum flavum hypertrophy, which can result in canal stenosis. The typical symptoms of ligamentum flavum hypertrophy induced spinal canal stenosis is a patient would have a difficulty in walking or standing. Now, if you remember the patient who was discharged yesterday from the 324, he had exactly the same clinical symptoms. He was having a pain only on walking or standing, and that's exactly the sign of ligamentum flavum hypertrophy. And in his MRI image, the ligamentum flavum thickness was around 4.5 millimeters, and that will be difficulty when standing following a period of sitting. Pain, numbness, tingling, burning, or weakness in the shoulders, arms if it is in the cervical area, or numbness in the buttocks, hips, thighs, knees, and so on also can occur as symptoms. And usually the patient would have a satisfactory response to our treatment protocol. Our treatment protocol would be the same, Kativasti, and maybe the same as I have suggested earlier, Abrakavasam Tapyadi Golante Avipatikara, and either Rajapanbasti or Niruhavastis are depending upon the patient's symptoms. If the patient has more of weakness, numbness, then I would prefer Rajapanbasti. If the patient has more of pain, then Dashamul Niruhavasti is given. And the treatment outcome would be much better than the contemporary treatment. Now, the other causes of the spinal canal stenosis are either where the stability of the vertebral column is altered, where either there could be an articulating process which could be affected, the articulating process between the superior and inferior spine, and hence the facet joints becomes unstable. So that the spinal canal stenosis could occur when there is an abnormal movement over there, or there could be facet hypertrophy where there would be increased thickening over the area, and that could be seen as a narrowing, the space become narrowed. And this also can result in a spot in this ankle, either kyphosis or scoliosis conditions. Usually these occur in the older age. Usually these changes are seen in the older age, and the patient would have a previous history of low back pain for a long time. Characteristically, the gait would be normal, and the pain would be when the patient would extend from the flexor position. In the flexor position, the pain would be comparatively lesser, but when the patient bends backwards, the pain would be presented. Characteristically, the pain would not be present in the leg. There will be no leg pain, and muscle spasm also would not be there. But and even the Valsalva's maneuver, like sudden jerky movement or increasing the abdominal pressure, doesn't aggravate the pain, but there will be a constant aching type of the pain in the back. The treatment usually is a spinal manipulation exercise, etc. The Kativasti and Niruhavasti, along with our medical treatment, which again usually that Ekalmibera and Abrakatapia are the same protocol of the treatment, can give the results, but most of the times the results require it requires multiple courses of the Kativasti. In a single course, the advantage would be lesser. Surgical treatment is another option. Surgical treatment again depends upon the fitness of the patient and other factors, but if the patient opts for surgical treatment, I would advise the patient to go for the surgery. Then comes another cause of the spinal canal stenosis, the vertebral body osteophytosis, or where there would be a gross osteophytic changes in the vertebral body, which results in the spinal canal stenosis. Now, this can be made out in the plain X-ray, as well as that can be made out with the MRI images, where the exact changes or compression of the spinal cord can be made out, and this also is called as a spondylosis deformans as such. In these conditions, the clinical presentation will be, there will be very gross pathology, and the very gross changes are seen. Clinically, when you palpate the vertebral column, there will be very gross changes. The spines would be prominent, or maybe interspinal space is reduced. Characteristically, the patient would have severe radicular pain, and sensory as well as motor signs would be presented. Outcome in these conditions is poor, both from surgical treatment or non-surgical treatment. With our treatment also, the outcome is poor. Generally, I would try to avoid those patients, but if the patient insists, then only after predicting the outcome, I would start with the treatment. With our treatment like Raja-Appan-Basti, there could be a marginal benefit, but it may not be as satisfactory as in the other condition. Then compression fractures, vertebral body compression fractures, which could occur either due to the trauma or due to the secondaries, which also can produce the spinal canal stenosis. Of course, these are obviously surgical conditions, and there is no question of these medical treatment at that stage. So, stabilization by surgical treatment is the first priority, and whether surgical treatment is possible or not would be depending upon the etiological factor, like whether it's a trauma or whether it's a tumor or so on. And the treatment is based upon the stability which causes the instability factors as such. So there is no question of specifying the standard protocol of the treatment. But if the patient has undergone surgery and then the stability has been established and then the symptoms do occur, in such conditions I would treat the patient exactly as we have discussed earlier about the canal stenosis protocol of the treatment. Then the other area where you will have more number of patients would be herniated nucleus pulposus, where the patient would have interrotator disc pathology and the disc becomes herniated, and a large number of patients whom we treat in the hospital, they are of this category where the patient would have spinal canal stenosis. Now, this is usually the typical advanced stages of that, where the MRI image can confirm that protrusion, bulging, and the canal being narrowed. Usually the clinical presentation would be like, usually it is in the younger age, and there would be some collagen tissue abnormalities also can occur. Occupational factors can mirror most of the times the patients who are in the sedentary job, and patients are usually obese. Sedentary lifestyle also is often seen in these patients. Of course, if you have the infrastructure to assess the proteoglycan level, the proteoglycan level may be higher, and usually the patient would have a poor physical fitness. Those who do not do exercise also are more prone for this condition. And in this treatment, again, the usual treatment is Raja-Appan-Basti, Ekangira, Abraka, Ashwagandha, Rishta, and so on. And the important is, if there is an atrophy of the muscle or there is a asensory area, lack of sensation is there, then surgical treatment is necessary. So in such conditions, I would advise the patient to go for surgery, would not continue with the medical treatment. The other options which are available in the contemporary interventional treatment are either epidural steroid injections, microdiscectomy or fragmentectomy, or percutaneous endoscopic lumbar discectomy, so on. Lots of other anterior cervical interbody fusions also, the vertebral body fusions also are tried. That depends upon the patient's condition, option of the treatment. So that's about the interrotator disc pathology is related to the lumbar vertebrae. Now the next part would be about the cervical spondylosis. Cervical spondylosis is again another very common condition, and as per the radiological findings, 90% of men older than 50 years and 90% of women older than 60 years have evidence of degenerative changes in the cervical spine, though they may not have the clinical symptoms. So degenerative changes in the cervical spine are very common after the age of 50 in males and after the age of 60 in females. Causes are repetitive cervical stress, stress on the neck due to either multiple factors like occupational factors or something like carrying the heavy weight or so on, or many times it could be the habits of the people, so on, or at times the symptoms may occur due to a single traumatic incident, some trauma occur, etc. And usually increased risk may occur due to vibrational stress. Vibrational stress in the sense, patients who have an occupation where there is a severe vibration of the neck area, like driving a vehicle and so on, heavy lifting, prolonged sedentary position, whiplash accidents where the neck is stretched, and frequent acceleration or deacceleration, sudden acceleration or sudden stoppage in a vehicle. Then the another factor is natural aging, also is considered as one of the causes, but it is natural aging is triggered by poor nutrition, smoking, atherosclerosis, job related activities, and genetics also are now known to be there. So a lot of information about the genetics are coming up in case of the spondylosis. I will not go into all that details now. Then nerve root compression may be as a result of the herniated disc, as we have discussed earlier, or stenosis, proteoglycan mediated chemical inflammation, protoglycan mediated chemical inflammation. Our simpler option of assessing this would be serum uric acid study. Smoking and occupational activities also predispose a patient to cervical pain. The cervical symptoms are initially the pain is vague, diffuse, and distributed in the midline. Pain is referred to from disc to the upper limb, usually in a non-dermatomal fashion, and in the sense that typical dermatomal limitations would not be seen. The patient may have a pain which is from the midline to the arm and does not allow predictable courses, like it can occur at any position. When you do the external rotation or internal rotation, the patient may not have that typical presentation of the pain, and that would be the initial condition of the cervical spondylosis. A good number of patients who come to our clinical conditions would be of that category. Then the activities that increase the intradiscal pressure, like lifting or Valsalva's maneuver. Valsalva's maneuver is holding the breath and then increasing the pressure in the pulmonary area, can intensify the symptoms. Whereas the other way, lying down supine would produce the relief of the pain. So usually such patients would say that when they lie down in a flat supine position, they would not have the pain. But using a pillow where the neck would be bent, that would be increasing the pain. That's the typical presentation of initial stages of the cervical disc pathologies or cervical spondylosis. Vibrational stress from driving also can exacerbate the initial pain. And these clinical symptoms of cervical spondylosis are staged as 3 stages. Cervical pain, as I told you earlier, which is the most common clinical symptoms. It could be inconsistent, like for a few days the patient may have a pain and then there could be a relief for a few days, then again there could be a recurrence. Then the other stage is radiculopathy and myelopathy, where the symptoms could be changing. Like a typical cervical pain would have chronic presentation of pain with headache, also may be presented occasionally, and mechanisms which can produce a compression of the nerves or degenerative disc conditions, joint pathologies, ligamentous lesions also can be presented as a history. And pain is usually felt locally. It may radiate to the occiput, shoulder, scapula, or the pain which is worse when the patient is in certain positions and can even interfere with sleep. In a radiculopathy, compression of the cervical nerve roots lead to the ischemic changes and cause a sensory dysfunction. There could be abnormal sensations which are felt, and or even motor dysfunctions where the range of movements could be reduced. And usually it occurs in the age of 40 to 50. And sensory examination and motor examination is an absolute necessity in such condition to rule out that. And herniated disc may even present with the severe radiculopathy or myelopathy. C6 root is the most commonly affected one because of the predominant degeneration of the C5-C6 interspace, and the next common sites are C7 and C5. Most cases of cervical radiculopathy resolve with conservative management. Few require surgical intervention. So majority of the radiculopathy conditions can be managed, and the majority of the patients whom we treat in our hospital, they are of that stage, cervical radiculopathy status. Like cervical myelopathy is the next stage where the spinal cord is affected, and it is the most serious consequence of the interorbital disc degeneration. Cervical spondylitis resulting in myelopathy is the most serious condition, and many of the old aged patients whom we have treated, they come at that stage, or maybe either the patients who have undergone surgery also, they are of that condition where there will be myelopathy, and when it is accompanied with the stenosis, and usually it becomes a gradual progressive condition. Usually the patients are at the older age, 50 to 60 years, and complete reversal is almost not possible in conditions. Some of the patients may have involvement of the sphincters, like micturition control or bowel control could be affected, and that would be based upon the severity. And the myelopathy, as such, the complications of the spinal cord, they are categorized into 5 categories: transverse lesion syndromes, motor syndromes, central cord syndrome, Brown-Sequard syndrome, and brachialgia and cord syndromes. We will have somewhat more discussion about the Brown-Sequard and brachialgia in the coming sessions. The others, of course, it means only transverse lesion syndrome is a where the patient would have a involvement of corticospinal and spinothalamic tracts, and hence the patient would have a difficulty in gait, abnormality of the gait could occur. Even it may mimic that of extrapyramidal or pyramidal symptoms. Motor syndrome involves the corticospinal, purely corticospinal, where voluntary activity will be affected as such. Central cord syndrome is where the patient would have involvement of upper extremities than the lower extremities. Hands are more involved than these. So these three syndromes do not make much difference, but we will discuss somewhat in detail in later sequences. Brown-Séquard syndrome, of course, it's not only related to the spinal pathology, and hence in the coming sessions we will discuss this in detail, where there is a speciality, like there would be a involvement of analgesia or absence of the pain on the other side. So that part we will discuss in the next session in detail. Then brachialgia, where the patient would have pain typically in the limb as such, and due to the long tract involvement. This also we will discuss somewhat in detail. In general, the spinal canal symptoms are diagnosed or may be categorized from the clinical point of view as postural syndromes, where the patient would have pain only at certain posture conditions, or dysfunctional syndromes, where the patient will have an impairment of the function, derailment, where there is a significant visible abnormality of the structures like either muscles or the bone structure, and this is what is named as McKenzie system as categorization. Confirmation of the clinical signs of these, or clinical signs to confirm the spinal canal or spinal spondylosis, cervical spondylosis, would be either swirling maneuver, where the patient's neck is extended and laterally bent and held down with the by pressure, which may produce a radicular syndrome. A positive test is the patient may have radicular pain along the nerve roots at that level. This, of course, the same test can be modified by just putting the pressure in the neck area, and it's a test which is specific by around 90 to 100%. It has a high specificity. The other test is shoulder abduction sign, where the active abduction of arm placing on the patient's head is performed in the seated position. Positive test finding is there is a relief or reduction of the pain. The patient would have somewhat relief in the area. This also is a very sensitive test which is usually done. If the patient has a relief on this, lifting the pain up, that suggests of radiculopathy, but there are no permanent organic changes as such. If the pain is due to some vascular pathologies, keeping the head arm on the head may aggravate the pain. Now, or even the bone pathologies of the joint, also it will be the same. Then another test which is often done is a neck distraction test, where the patient is made to lie down either in the supine position or in the erect posture, and you just extend the neck, pull the neck apart. As the space between the vertebral bodies are increased down, the patient would have a relief of the pain. So relief of the pain by putting a force of around 10 to 15 kg to extend the neck is seen, and this also is around sensitive by around 40 to 43%. Valsalva's maneuver or Valsalva's test is the patient's mouth is closed and the patient is made to blow so that the pulmonary pressure is increased. Now, during this stage, there will be some movement of the neck vertebra, and particularly in the early stages of the spondylosis, this test would be positive. If the vertebral bodies have become fixed, orthodesis has occurred, then this would be negative, and it can just confirm like whether the cervical vertebral bodies are stable or unstable. So that's all the observation, and it could occur due to multiple causes like tumors or trauma, fractures, and so on. Another of the test is shoulder extension test, where the patient is made supine and lying down in the supine position, and the arm is extended, which produces capillary depression. Shoulder is abducted, and the forearm is supinated. And then the shoulder is rotated externally, elbow is extended, and there could be pain which is maybe the pain which is felt in the area. If the symptoms of pain are produced, that is a positive condition as such. And side to side in the extension of the shoulder, if you turn to by 10 degrees, the pain is felt either in the same side or on the opposite side. By that you can make out the diagnosis. Another of the sign which is usually done is Hoffman sign, where if you nip the middle finger, the other fingers will be flexed, which also is a sign of compression of the cervical nerve roots, and it's also usually seen in brachial neuralgia. That part we will see that. The confirmation of the diagnosis is done better by MRI images. In the MRI images, radiculopathy, where the radicals, the nerve roots being swollen and the facet joints being swollen, or the space being reduced, can be easily made out with the MRI scan. Myelopathy, where the spinal cord is compressed and damaged, that can be easily made out by the MRI scan. So MRI scan is the usual investigation. Treatment protocol. The usual earlier stages, the ideal treatment, earlier stages of these lesions, ideal treatment suggested by the universal program would be the exercises, and that the McKenzie's exercise is considered as one of the standard protocol, where the cervicothoracic stabilization program is considered as cervicothoracic stabilization program. But instead of going for all that, I would suggest Surya Namaskara. Surya Namaskara is much better than and much effective than all these complex exercises. So that McKenzie's exercise is something of aberration, which I generally don't recommend. It's only from the theory point of view. Theory is the McKenzie exercise, but I will always recommend the patients to have Surya Namaskara. Then there are the other most complex procedures which are used by physiotherapists for cervicothoracic stabilization, cervical vertebral body exercises. There are huge type of exercise. Maybe it looks attractive to some people. This may be suggested, which I generally don't. I suggest only this. The other options are cervical braces, the different sorts of either the soft or the relatively hard belts which are used. Usually, the medical management which I prefer would be as in case of the lumbar pathology. Similarly, Gokshiraldi, BMT, or Ekakvira, and so on. Tailadhara is usually preferred. That's the usual treatment in case of the cervical vertebral bodies. Complications which can occur could be cervical myelopathy, that could be paraplegia, tetraplegia. You have many of the patients in the tetraplegia also. Recurrent chest infections, bed sores, recurrent urinary tract infections can occur, which can produce the complications. Indications for the surgery would be if there is a progressive neurological deficit, or there is a compression of the cervical nerve root which is obviously visible, if the patient is having intractable pain. And the treatment, surgical treatment, could be of different sorts, either the anterior approach or the posterior approach. Of course, that detail is not necessary. The last part of the discussion will be thoracic disc injuries. Thoracic disc injuries are less common because of the basic structural stability of the thoracic vertebrae. Incidence of thoracic disc injuries is just 1 in 1 million persons per year, and these injuries account for only 0.25 to 0.75% of all disc herniations. But when they occur, the usual causes are either old age, trauma, sport injuries are the more common, smoking, obesity, sedentary lifestyle, and poor physical fitness. The clinical symptoms will be high thoracic symptoms, the herniation conditions, they mimic cervical disease only, exactly the similar clinical symptoms occur. Shooting down pain down the legs suggests of nerve root irritation and cord compression. And pain in the thoracic area signifies mechanical pain that's possibly secondary to fractures, degenerative disc diseases. Now, from the clinical point of view, whenever a patient comes with the thoracic pain, it's absolutely necessary that you go for all the investigation protocol, because a simple disc bulge would be less common, and most of the times there will be some serious underlying pathology, either like tuberculosis, tumor, etc., which require a more energetic and specific treatment. And particularly if the patient has a thoracic pain which makes the patient wake up at night, then it could be suggestive of such serious conditions like infection, like tubercular or oncological condition. And if the patient has a sign of clonus, muscle spasm, and Babinski reflex is positive, suggestive of upper motor leader conditions, or if there is a bowel and bladder dysfunction, that's a definite sign of cord compression and myelopathy, which is beyond the scope of usual medical treatment. Now, otherwise, if it's only a thoracic disc lesion, majority of the conditions would heal by themselves. It's a self-limiting condition as such. If it's only a disc bulging or even minor trauma, it's a self-limiting condition which doesn't require any energetic treatment. The usual treatment protocols which are suggested are cold heat therapy, ultrasound and rest. Exercises with low impact exercises could be treated. Surgical decompression is only when the patient has a myelopathy. I would prefer to use prescribe only Gokshuraji and Purnamamagura for a few days, and that would be usually subsiding. With this, we will conclude today, and in the next, we will consider other spinal canal syndromes like Brown-Sequard syndrome and so on. There are some questions. Uh, what should be the treatment for disc lesion due to pregnancy induced weight gain, etc.? So it's the same treatment protocol is the same, but if the patient is in the stage of pregnancy, you may not follow the treatment. The treatment is followed or done only after the pregnancy or after the perperium. That's all the issue. Then what is the rationality behind abracadabra? In Dhatukshaya Janyamadi, see, only in the advanced stages of osteophytes, I think I have suggested that patients who have osteophytic changes, then the that's suggestive of the degeneration or Dhatukshaya, and that's in the Dhatukshaya condition, abracadabra is a better treatment as such. Then can you show the disc bulge protrusion again in MRI? I think I think this would suggest about the same, where there is a disc bulge in the MRI. Right. Okay. With this we will conclude.